Thank you, Dr. Rania, and I'd like to thank the organizers. And this is truly a pleasure for me to be presenting here today with my radiology colleagues and my radiology professors. So my talk is about the symptomatic young adult hip, and we're going to have a clinical overview of what that is. So first, I would like to start with the story of this 22-year-old lady who lives in a small village in the northern part of England. She complained of hip pain for a year, went to her general practitioner, who did an x-ray, didn't find much, prescribed her analgesia, and sent her to physiotherapy. She came back a year later still complaining of hip pain, did an MRI scan, which again was reported as normal, and again received analgesia. At the age of 25, she got married, 26, she got pregnant, and then they moved to another city. And in that other city, they went to a different general practitioner who this time did an MRA, a magnetic resonance imaging of her hip, and discovered the labral tear. At that point, he sent her to physiotherapy once again. She had an injection in the hip, and this did improve her symptoms for around 6 months. When she didn't improve, he sent her for a specialist opinion of a young adult hip orthopedic surgeon. At that point, she was 29 years old. He told her, your problem is not a labral tear, you have hip dysplasia. Found that out by measuring the acetabular index, which was 18 degrees, the lateral central edge angle, which was 18 degrees, and the acetabular index, which was 20 degrees. And when they did a new MRI scan, they found that she had already started to develop degenerative changes in the hip. At that point, she was not suitable for a hip preservation procedure, and she was told to try to live with the pain. 2 years later, she ended up having a hip replacement. So the point of this story really is it acceptable for this to happen, for someone to be sent for physiotherapy and be given analgesia without getting a proper diagnosis? This is the problem we see every day in our practice. So what is a young adult hip patient? When we talk about a young adult hip patient, we're usually referring to the age group between 16 and 55 years of age. Why this age group in particular? Because they have a set of different pathologies. Intra-articular pathologies such as hip dysplasia, femoroacetabular impingement, extra-articular pathologies such as rotational deformities and trochanteric pain syndrome, which we will discuss in this study. First, we'll talk about the adult hip dysplasia. So probably most of us are aware with the term DDH, or developmental dysplasia of the hip. This is when it is diagnosed in the newborn, and if it is treated well, it might result in full cure. However, we're here concerned with the adult form of hip dysplasia. So this is either dysplasia that was not picked up during childhood or a subtle form of dysplasia which presents at the teen ages, so between the ages of 16 and 40. If they come after that, then they usually present with osteoarthritis. So how do we diagnose hip dysplasia? The plain X-ray is the most important imaging we can get, and this is the problem we always encounter, that these patients tend to get an MRI scan and they do not get an X-ray. And if they get an X-ray, and if we do measure the indices, then we will discover that this is dysplasia. There are two important angles we measure. The lateral central edge angle, this should be above 25. Anything below is dysplasia. The acetabular index, this should be below 11. If it is above 11, then this is dysplasia. And the MRI role here is only to rule out degenerative changes in the hip. So what happens in hip dysplasia? So instead of the force being distributed over a large surface area, it is distributed on a small surface area. This then results in pain, results in labral tears, and then results in arthritic changes of the hip. So how do we treat it? We treat it mainly surgical, through what is called a periacetabular osteotomy. We do this through a cut in the superior pubic ramus, another cut in the ischium, or the inferior pubic ramus, and a third cut in the ilium. This will then free the acetabulum, and we can rotate or move the acetabulum accordingly to cover the deficiency in the acetabulum. This is then fixed with screws and plates. So this is an example of a 20-year-old lady, and you can appreciate the deficiency of the femoral head coverage, but it's not just enough to look at the X-ray. You have to measure the angles to detect the dysplasia, and here the acetabular index is definitely more than 11 degrees. And this was she had a periacetabular osteotomy, and you can see the difference of the femoral head coverage, and you can see the change in the acetabular index following the procedure. So what are the outcomes of the periacetabular osteotomy? 80% of these patients do have an improvement of their symptoms. They get an 80% reduction in the risk of them needing a hip replacement later on in their lives. But however, the older they are, then the less successful these surgeries are. That's why it is very important to pick up these cases early on in their life before they develop degenerative changes. What about labral tears? We've been seeing this a lot, and we've been talking about it a lot. Well, for a labral tear to happen, there has to be a problem. That problem has to be mechanical. So either instability, such as dysplasia, which we just discussed, or impingement, what we call femoroacetabular impingement. Most of us have heard about FAI, and we know that there's a CAM type, a pincer type, and a combined type. But what really happens? What happens is, instead of having a spherical round femoral head, you get an aspherical femoral head. That's called a CAM lesion. Or you get a protrusion of the acetabulum, or an over coverage of the acetabulum. So these asphericities that happen in the hip, they then will collide together or impinge together when the patient is doing his daily activities or performing sports. This will then cause a tear in the labrum and later on cause degenerative changes in the hip. When we examine these patients, the most important thing we look for is the impingement test, which is flexion with internal rotation of the hip. This reproduces the patient's pain, and the flexion abduction external rotation, or the Faber test, to test for posterior impingement. There's also the dynamic internal rotation test, where we test for labral pathology in the anterosuperior labrum, and the dynamic external rotation test, where we test for labral pathology in the posterior part of the acetabulum. So in the X-ray, you can appreciate the aspherical head, but the AP X-ray alone is not enough, because the impingement does not happen in this plane. The impingement happens anteriorly. So to look for the anterior CAM, we need a cross-table lateral view of the hip. So here we can appreciate the anterior CAM, and this is what's going to impinge over the acetabulum. And from here we can measure the alpha angle, which is normally should be less than 50. So, and we have to also differentiate between FAI, or hip impingement syndrome, and the CAM morphology. So in this study, which was done in Asr Al Ain, we found that up to 60% of males in this country have a CAM lesion or have a pincer lesion. This does not mean that all of them have FAI, only the symptomatic ones. So not all CAM lesions mean FAI, and not all FAI means surgical intervention. So how do we treat FAI? Mainly through hip arthroscopy. So the aim here in hip arthroscopy is to repair the labrum and to remove the CAM or the pincer. We do this surgery through using a hip arthroscopy table. This table enables us to examine the hip in various positions to detect impingement with flexion and extension all the way. And then we have to distract the hip. So we put traction on the hip and open the hip about 1 centimeter and 1.5 centimeters, so we can bring in our surgical instruments to the hip. And then through 2 portals, or maybe 3 portals, we can access the hip. And in there we can see the pathology. So this is the labrum, and you can appreciate the tear on the undersurface of the labrum. So this is the articular side of the labral tear, which is the part that is important to us. And you can see the acetabular cartilage, the fossa, the ligamentum teres, and the femoral head. And then here is the labrum, the torn labrum, and it's being repaired with an anchor, and the labrum is being attached to the acetabular rim. This is the peripheral compartment, or the femoral head-neck junction, where we are doing a CAM resection using a burr. So the burr then removes the extra bits of bone to change the head back into a spherical shaped head. And here are the intraoperative images. So you can see in the first image here, you have a CAM lesion, and this is after the resection of the CAM. and you can see the spherical configuration of the head. Another thing we always are concerned with in these patients are rotational deformities. So the moment the patient walks into our clinic, we have a look at the way they walk. So if they're walking with an X-towing gait, this could mean femoral retroversion. If they walk with an in-towing gait, this could mean excessive femoral anteversion. Even the way they sit on the chair could give us an indication whether they have femoral anteversion or femoral retroversion. And we have to examine these patients and look at their rotation. If they have too much external rotation, femoral retroversion. If they have too much internal rotation, excessive femoral anteversion. And I won't be able to go through all the deformities, but if we take this one as an example, this is acetabular retroversion. So what happens in acetabular retroversion? The acetabulum is retroverted, so moves backwards, looking backwards. This causes impingement at the front of the hip and causes a tear of the labrum at the front of the hip and causes hip pain anteriorly. And on the X-ray, there are two important signs we look for, called the crossover sign and the ischial spine sign. The crossover sign is the crossing between the anterior and posterior wall of the acetabulum, and the ischial spine sign is a prominent ischial spine due to the retroverted acetabulum. Acetabulum looking backwards, so ischial spine prominent anteriorly. And you can look at this 19-year-old girl, and you can look that she has retroversion signs in the acetabulum, she has a crossover sign, and she has a prominent ischial spine sign. And this is her CT scan, and you can see that in the apical part of the acetabulum is retroverted around 24 degrees. And in the center of the acetabulum, it is anteverted only by 6 degrees, where the normal is 10 to 25 degrees. Another important pathology we see a lot is greater trochanteric pain syndrome. Now, this was formerly known as trochanteric bursitis. It's not just about trochanteric bursitis, as we had previously thought. This is a syndrome, a more complex syndrome that involves muscle imbalance, iliotibial band tightness, gluteal tendinopathy, together with inflammation of the bursa. Because the inflammation of the bursa is the only thing we see in our imaging, so people diagnose it as trochanteric bursitis, but there is a bigger picture. So why does it happen? It's not really fully understood, but it's thought to be because of some imbalance that happens, and it happens more in women in their 30s and 40s than it happens in men. Why does it happen in women? There are theories about different gait patterns and different standing patterns between women and men. You can see how this is the extreme form of women's gait, but you can see that in the catwalk, you can see how the hips truly have some sort of imbalance that's happening here, and this leads to the lateral hip pain. And we always see the trochanteric bursitis or the GTPS with other hip pathologies. So we see it as part of osteoarthritis, we see it as part of dysplasia, and we see it as part of femoroacetabular impingement. In the extreme forms of greater trochanteric pain syndrome, you can either get a snapping hip, so this is the external snapping hip due to tightness of the iliotibial band, which we can either detect clinically or we can detect via dynamic ultrasound assessment. Greater trochanteric pain syndrome is mainly treated with physiotherapy. Injections also have a role. However, surgery is usually our last resort because the results of surgery are not that good. Anterior hip pain could be due to the dysplasia, could be due to FAI, but could also be due to iliopsoas tendinopathies. And clinically, we examine this when hearing a click or getting pain from moving the patient's hip from flexion and internal rotation to extension and external rotation. And psoas pathology, we usually treat this again with physiotherapy, injections, and as a last resort, we could do arthroscopic lengthening of the psoas tendon. Medial hip pain, usually due to either adductor strains or pubic symphysis dysfunction. We see this a lot in football players. Posterior hip pain, the number one cause of posterior hip pain is pain referred from the spine. So posterior hip pain, number one, we have to rule out spinal pathology, we have to rule out disc lesions, and then we can think of posterior structures such as hamstring tendinopathy or ischiofemoral impingement, which is a narrow space between the ischium and the lesser trochanter of the femur, causing impingement of the quadratus femoris muscle. So in summary, Young adult hips presenting with hip pain need special assessment, they need special attention. Assessment relies on clinical examination and on radiological assessment. It is not acceptable at all to have some young adult with hip pain and not reach a diagnosis and just rely on painkillers and rely on physiotherapy without reaching a diagnosis. And if we are unsure of the diagnosis, then we should refer further onwards. Thank you.